Hello, future lifesavers and healthcare heroes. Today, we're diving into a fascinating and complex area of medicine autoimmune diseases. Imagine your body's defense system, the immune system, as a highly trained army. Its mission is to protect you from foreign invaders like bacteria, viruses, and other harmful pathogens. It's an incredibly sophisticated network of cells, tissues, and organs working around the clock to keep you healthy. This system is brilliant at recognizing what belongs in your body, what we call self, and what doesn't belong, or non-self. It's a fundamental concept that keeps us safe from countless threats every single day. But what happens when this finely tuned system makes a mistake? What if this vigilant army loses its ability to distinguish friend from foe? This is the core of autoimmunity. An autoimmune disease occurs when the immune system mistakenly identifies the body's own healthy cells, tissues, or organs as foreign invaders and launches an attack against them. Instead of fighting off a cold, it starts a civil war, causing inflammation and damage to parts of the very body it's supposed to protect. It's a case of friendly fire on a microscopic level, with significant consequences for a person's health and well-being. This misguided attack leads to a state of chronic inflammation, which can manifest in a huge variety of ways depending on which part of the body is being targeted. There are over 80 different types of autoimmune diseases known to science, and they can affect nearly any part of the body, from the skin and joints to the brain and vital organs. Some of these conditions are relatively common, like rheumatoid arthritis or psoriasis, while others are quite rare. Understanding this fundamental breakdown in self-tolerance is the first step for any medical or nursing student wanting to grasp how these challenging conditions develop and how we can help patients manage them. The causes behind this immune system malfunction are not always clear-cut. It's often a complex interplay of genetic predisposition, environmental triggers, and sometimes just sheer bad luck. Think of it as a perfect storm of factors. Someone might be born with certain genes that make them more susceptible, but the disease might not activate until they encounter a specific virus, a chemical, or another environmental factor. This is why you'll see autoimmune diseases run in families, but not every family member will develop one. Our journey today is to demystify these conditions, making them easier to understand, recognize, and ultimately, treat. When we talk about autoimmune diseases, it's helpful to categorize them into two main groups based on the scope of the immune system's attack. This classification helps us understand the pattern of the disease and predict its potential effects on the patient. The first category is organ-specific autoimmune disease. As the name suggests, in these conditions, the immune system's misguided attack is focused on a single specific organ or tissue. The autoantibodies and T cells involved are trained to recognize and destroy antigens that are unique to that one particular part of the body. A great example of an organ-specific disease is type 1 diabetes, where the immune system specifically targets the insulin-producing beta cells within the pancreas. Another is Graves' disease, where the thyroid gland is the sole target of the autoimmune assault. In these cases, the symptoms are directly related to the damage or dysfunction of that one organ. For a patient with type 1 diabetes, the symptoms all stem from the pancreas's inability to produce insulin. This targeted nature makes the diagnosis at times more straightforward, as the clinical signs point clearly to a single malfunctioning organ system. On the other side of the spectrum, we have systemic autoimmune diseases, which are also known as non-organ specific. Here, the immune system's attack is much more widespread. It doesn't target just one organ. Instead, it goes after antigens that are common to many different cells and tissues throughout the entire body. The autoantibodies produced are more generalized, reacting with components like DNA or other proteins found in the nucleus of almost every cell. This results in a broad, multi-system inflammatory response that can affect the skin, joints, kidneys, heart, lungs, and more, all at the same time. Classic examples of systemic autoimmune diseases include rheumatoid arthritis, which primarily targets the joints but can affect the skin, eyes, and lungs, and systemic lupus erythematosus, or simply lupus. Lupus is famous for its ability to impact virtually any part of the body, leading to a vast and varied range of symptoms that can make diagnosis incredibly challenging. For you as future clinicians, recognizing the difference between an organ-specific and a systemic process is vital. It will guide your diagnostic thinking, helping you know whether to look for a focused problem or to prepare for a complex, multi-organ puzzle. To truly understand autoimmunity, we need to talk about a crucial part of our genetic makeup: the human leukocyte antigen system. Think of the HLA system as your body's personal identification system. Every cell in your body carries a set of these HLA molecules on its surface. These molecules act like a unique barcode or an ID card, presenting tiny fragments of proteins from inside the cell to the outside world. This allows patrolling immune cells, particularly T cells, to scan them and determine if the cell is safe and healthy, or if it's foreign or infected. It's a constant security check happening all over your body. These HLA molecules are encoded by a large family of genes located on chromosome 6, known as the major histocompatibility complex. Because we inherit these genes from our parents, our HLA type is unique to us, much like a fingerprint, unless you have an identical twin. This system is absolutely essential for a normal immune response. When a cell is infected with a virus, for instance, it will display fragments of viral proteins on its HLA molecules. A passing T cell will recognize this foreign fragment, sound the alarm, and initiate an immune response to destroy the infected cell. This is how we fight off infections. So what does this have to do with autoimmune diseases? Well, research has shown a very strong link between certain HLA types and a higher risk for developing specific autoimmune conditions. It seems that some HLA molecules are not as good at distinguishing between self-proteins and non-self-proteins, or in some cases a particular HLA variant might be exceptionally good at presenting a specific self-protein in a way that makes it look foreign to the immune system. This genetic predisposition doesn't mean you will definitely get the disease, but it significantly increases your susceptibility. For example, the HLA-DR3 and HLA-DR4 alleles are strongly associated with an increased risk for both type 1 diabetes and rheumatoid arthritis. Another variant, HLA-B27, is famously linked to a condition called ankylosing spondylitis. It's like having a security system that is a little too sensitive. It's more likely to trigger a false alarm. Understanding the role of the HLA system is critical for us as clinicians because it helps explain the genetic component of these diseases and is becoming increasingly important in diagnostics and even in predicting disease risk for patients and their families. Let's start our deep dive into specific diseases with one of the most well-known organ-specific autoimmune conditions, insulin-dependent diabetes mellitus, or type 1 diabetes. This disease typically develops in childhood or young adulthood, which is why it was once called juvenile diabetes. At its heart, type 1 diabetes is a disease of the pancreas. Specifically, it involves the targeted destruction of the beta cells, which are located in clusters called the islets of Langerhans within the pancreas. These beta cells have one incredibly important job: to produce and secrete insulin, the hormone that regulates our blood sugar levels. In a person with type 1 diabetes, the immune system, particularly cytotoxic T lymphocytes, mistakenly identifies these hardworking beta cells as a threat. It launches a precise and relentless attack, infiltrating the islets of Langerhans and systematically destroying the beta cells. This specific inflammation of the islets is called insulitis. As more and more beta cells are destroyed, the pancreas's ability to produce insulin diminishes. Without insulin, glucose from the food we eat cannot get into our cells to be used for energy. Instead, it builds up in the bloodstream, leading to high blood sugar levels, or hyperglycemia. The symptoms of type 1 diabetes are a direct result of this process. The classic signs are often referred to as the 3 Ps, polyuria, frequent urination, as the kidneys work overtime to flush out the excess sugar; polydipsia, increased thirst due to the dehydration caused by frequent urination; and polyphagia, increased hunger, because even though there's plenty of sugar in the blood, it can't get into the cells to provide energy, leaving the body starving. Weight loss is also common, as the body starts breaking down fat and muscle for fuel. If left untreated, this can lead to a life-threatening condition called diabetic ketoacidosis. Managing type 1 diabetes is a lifelong commitment. Since the body can no longer produce its own insulin, patients must administer insulin externally, either through multiple daily injections or via an insulin pump. They also need to constantly monitor their blood glucose levels to ensure they stay within a safe range. As future healthcare professionals, a huge part of your role will be educating and supporting patients with type 1 diabetes. You'll help them understand their condition, manage their treatment regimen, and navigate the daily challenges of living with this chronic autoimmune disease, empowering them to lead full and healthy lives. Next, let's explore myasthenia gravis, a fascinating and classic example of an organ-specific autoimmune disease that affects the way our nerves and muscles communicate. The name itself comes from Greek and Latin, meaning grave muscle weakness. This condition is characterized by fluctuating weakness and fatigue of the voluntary muscles, the ones we consciously control. The weakness typically gets worse with activity and improves with rest. It can affect any voluntary muscle, but it often first appears in the small muscles that control eye and eyelid movement, leading to droopy eyelids, which we call ptosis, and double vision, or diplopia. The problem in myasthenia gravis occurs at a very specific location, the neuromuscular junction. This is the tiny gap where a nerve ending meets a muscle fiber. To make a muscle contract, the nerve releases a chemical messenger called acetylcholine, or ATH. This acetylcholine travels across the gap and binds to specific acetylcholine receptors, or AChRs, on the muscle fiber's surface. This binding event is like a key fitting into a lock, which then triggers the muscle to contract. It's a precise and rapid process that happens millions of times a day, without us ever thinking about it. In myasthenia gravis, the immune system produces autoantibodies that target and attack these acetylcholine receptors. These antibodies disrupt communication at the neuromuscular junction in three main ways. First, they can simply block the receptor, preventing acetylcholine from binding to it. Second, they can cause the receptors to be internalized and destroyed by the muscle cell more quickly than they can be replaced. And third, they can activate a part of the immune system called the complement system, which directly damages the muscle membrane where the receptors are located. The end result is the same. Fewer functioning receptors are available for acetylcholine. With fewer available receptors, the signal from the nerve to the muscle becomes weaker and less effective. When the muscle is used repeatedly, the amount of acetylcholine released by the nerve can temporarily decrease, making it even harder to trigger a contraction. This is why the muscle weakness in myasthenia gravis worsens with exertion. Treatment for this condition focuses on improving neuromuscular transmission and suppressing the autoimmune response. This can include medications that increase the amount of acetylcholine in the junction, as well as immunosuppressive drugs to reduce the production of those harmful autoantibodies. Now let's turn our attention to the thyroid gland, a small, butterfly-shaped organ located at the front of your neck. This gland produces hormones that regulate your body's metabolism, controlling everything from your heart rate to how quickly you burn calories. Hashimoto thyroiditis, also known as chronic lymphocytic thyroiditis, is an organ-specific autoimmune disease where the immune system attacks the thyroid gland. It is the most common cause of hypothyroidism or an underactive thyroid in areas of the world with sufficient iodine intake. This condition tends to affect women much more often than men. The autoimmune attack in Hashimoto's is a slow and progressive process. It involves both immune cells, T lymphocytes, and autoantibodies. The T cells infiltrate the thyroid gland, causing chronic inflammation and gradual destruction of the thyroid follicular cells, which are the cells responsible for producing thyroid hormones. At the same time, the body produces autoantibodies against key thyroid proteins, most commonly against thyroid peroxidase or TPO, and thyroglobulin. These antibodies serve as important markers for diagnosing the disease, but it's the cellular destruction by T cells that is the primary cause of the gland's failure. As the thyroid tissue is slowly destroyed, the gland's ability to produce thyroid hormones, thyroxine or T4, and triiodothyronine or T3, declines. In the early stages, the patient might not have any symptoms, or the gland might even release a surge of hormones from the damaged cells, causing a temporary state of hyperthyroidism. But over time, as the destruction progresses, the thyroid becomes unable to meet the body's needs. The pituitary gland in the brain will sense the low hormone levels and release more thyroid-stimulating hormone or TSH to try and whip the thyroid into action, but the damaged gland simply can't respond. This resulting state of hypothyroidism leads to a general slowing down of all bodily functions. Patients often experience fatigue, weight gain, constipation, sensitivity to cold, dry skin, hair loss, and a slowed heart rate. They might also develop a goiter, which is an enlargement of the thyroid gland due to the constant inflammation and stimulation by TSH. The treatment for Hashimoto's is typically straightforward, replacing the missing thyroid hormone with a daily dose of a synthetic hormone called levothyroxine. This hormone replacement therapy is usually lifelong but is highly effective at managing the symptoms and restoring normal metabolic function. While Hashimoto's causes the thyroid to slow down, Graves' disease does the exact opposite. It's another organ-specific autoimmune disease targeting the thyroid, but in this case the autoimmune response puts the gland into overdrive, causing hyperthyroidism or an overactive thyroid. Like Hashimoto's, it is much more common in women. Graves' disease is the most common cause of hyperthyroidism, and it presents a unique mechanism of action that is fascinating for students to understand. It's a perfect example of how autoantibodies don't always have to be destructive. Sometimes they can be stimulatory instead. The key player in Graves' disease is a specific type of autoantibody known as the thyroid-stimulating immunoglobulin, or TSI. These antibodies are directed against the receptor for thyroid-stimulating hormone, or TSH, on the surface of thyroid cells. Normally, TSH, which is released from the pituitary gland, binds to these receptors to tell the thyroid to produce and release its hormones. It's part of a finely balanced feedback loop. However, the TSI antibodies are shaped in such a way that they can also bind to and activate these TSH receptors, just like TSH itself does. The crucial difference is that while the pituitary gland's release of TSH is carefully regulated, the production of TSI antibodies is not. These antibodies constantly stimulate the thyroid gland, telling it to produce more and more T4 and T3, regardless of the body's actual needs. This leads to excessively high levels of thyroid hormones in the blood. The pituitary gland senses these high levels and shuts down its own TSH production, but it doesn't matter. The TSI antibodies have hijacked the system and are keeping the thyroid's accelerator pedal pushed firmly to the floor. This constant overstimulation leads to the classic symptoms of hyperthyroidism: weight loss despite an increased appetite, rapid or irregular heartbeat, nervousness and anxiety, tremors, sweating, and heat intolerance. Many patients also develop a goiter, as the gland enlarges due to the continuous stimulation. A unique feature of Graves' disease is Graves' ophthalmopathy, where the tissues and muscles behind the eyes become inflamed and swollen, causing the eyes to bulge forward, a condition called exophthalmos. Treatment aims to reduce the production of thyroid hormones using anti-thyroid drugs, radioactive iodine therapy to destroy thyroid tissue, or surgical removal of the thyroid gland. Finally, let's discuss rheumatoid arthritis, or RA, a classic example of a systemic autoimmune disease. While it is most famous for its effects on the joints, it's important to remember that RA can affect many other parts of the body, including the skin, eyes, lungs, and blood vessels. RA is a chronic inflammatory disorder where the immune system primarily mounts an attack on the synovium, which is the soft tissue lining the inside of our joints. This lining normally produces a fluid that lubricates the joint, allowing for smooth, painless movement. RA is a significant cause of disability and affects millions of people worldwide. In rheumatoid arthritis, the immune system gets confused and sees the synovial membrane as a foreign threat. Immune cells, including T cells and B cells, flock to the joint, triggering a powerful inflammatory response. The B cells produce autoantibodies, most notably rheumatoid factor, or RF, and anti-citrullinated protein antibodies, or ACPA, which are key diagnostic markers. This chronic inflammation causes the synovium to thicken and swell, forming an abnormal, destructive layer of tissue called a pannus. This pannus can grow to cover the joint's cartilage, the smooth tissue that cushions the ends of the bones. The pannus is not just a passive layer, it's an aggressive, invasive tissue. It produces enzymes that actively erode the cartilage and eventually the bone underneath. This destruction is what leads to the characteristic features of RA joint pain: stiffness, especially in the morning, swelling, and a loss of function. Over time, this ongoing damage can cause severe joint deformity and instability. While RA can affect any joint, it most commonly starts in the small joints of the hands and feet, typically in a symmetrical pattern, meaning if a joint on the left hand is affected, the same joint on the right hand often is too. Because RA is a systemic disease, the inflammation is not confined to the joints. Patients can experience widespread symptoms like fatigue, fever, and a general feeling of being unwell, or malaise. They may also develop rheumatoid nodules, which are firm lumps under the skin, often over bony areas like the elbows. Modern treatment for RA has improved dramatically, and focuses on controlling the inflammation to relieve symptoms and, more importantly, to prevent or slow down the progression of joint damage. This involves using disease-modifying anti-rheumatic drugs, or DMARDs, and newer biologic agents that target specific components of the immune response. We've covered a lot of ground today, from the basic concept of autoimmunity to the specific mechanisms of several major diseases. We've seen how the body's own defense system can turn against it, targeting a single organ like the pancreas in type 1 diabetes, or waging a widespread war on the joints in rheumatoid arthritis. We've learned that these diseases often involve a combination of genetic risk factors, like specific HLA types, and environmental triggers that set the process in motion. This knowledge is the foundation upon which you will build your clinical expertise. As medical, nursing, and allied health students, you are stepping into a field that is constantly evolving. What we know about autoimmune diseases today is vastly more than what we knew just a decade ago, and our understanding will continue to grow. New discoveries are leading to more targeted and effective treatments, transforming the lives of patients who live with these chronic conditions. Your commitment to lifelong learning is not just a professional requirement, it's a promise to your future patients that you will always strive to provide them with the best possible care based on the most current knowledge. Remember that behind every diagnosis, every lab result, and every complex mechanism, there is a person. A person navigating the daily challenges of their condition, managing medications, and dealing with the physical and emotional impact of a chronic illness. Your role will be to combine your scientific knowledge with compassion and empathy. You will be their educator, their advocate, and their partner in health. Understanding the why behind their disease is the first step toward building that crucial therapeutic relationship and empowering them on their health journey. This deep dive is just the beginning. The world of medicine is vast, and the journey of learning is endless. Stay curious, ask questions, and never stop seeking knowledge. The more you understand the intricacies of the human body and the diseases that affect it, the more effective and compassionate a healthcare provider you will become. You are the future of medicine, and your dedication to learning today will save and improve lives tomorrow. Keep pushing, keep studying, and embrace the incredible opportunity you have to make a difference. For more clear, concise, and engaging medical education to help you excel on your exams and in your future practice, be sure to check out what we're building at Joen Academy. We're dedicated to providing you with the high-yield information you need to succeed. Join our community, and let's continue this journey of learning together.